Question 1. Quality control measures reveal a discrepancy in the documented innervation of the superior oblique muscle for a patient undergoing evaluation for strabismus. The initial examination notes indicate innervation by the oculomotor nerve, CN Roman 3, while a subsequent review suggests trochlear nerve, CN Roman 4, innervation. Which of the following actions best addresses this discrepancy according to the principles of ophthalmological practice and patient record integrity? Option A. Immediately correct the record to reflect trochlear nerve, CN Roman 4 innervation, assuming the quality control review is accurate and the initial documentation was an error. Option B. Dismiss the discrepancy as a minor clerical error, as the functional deficit is the primary concern for patient management. Option C. Consult general anatomical texts to confirm the typical innervation of the superior oblique muscle without reviewing the specific patient's documentation. Option D. Review the patient's complete medical record, including the original examination notes, diagnostic imaging, and any previous ophthalmological consultations, to determine the correct innervation based on anatomical and physiological principles. Correct answer is D. Review the patient's complete medical record, including the original examination notes, diagnostic imaging, and any previous ophthalmological consultations, to determine the correct innervation based on anatomical and physiological principles. Explanation. Scenario analysis. This scenario presents a challenge in ensuring accurate and consistent patient care related to ocular muscle function. A discrepancy in the documented innervation of a specific extraocular muscle during a routine quality control review highlights a potential breakdown in the established diagnostic and documentation protocols. The professional challenge lies in identifying the source of this discrepancy, understanding its clinical implications, and implementing corrective actions to maintain the highest standards of patient safety and diagnostic accuracy, all within the framework of American Board of Ophthalmology guidelines and accepted ophthalmological practice. Correct approach analysis. The correct approach involves a thorough review of the patient's chart, including the initial examination findings, any subsequent diagnostic tests performed, and the specific documentation of the extraocular muscle assessment. This systematic review allows for the identification of the precise point of error or variation in interpretation. By cross-referencing the documented innervation with established anatomical and physiological knowledge of cranial nerve control over ocular muscles, the ophthalmologist can determine the correct innervation. This adherence to established medical knowledge and diligent chart review represents best professional practice by ensuring accurate diagnosis and treatment planning, directly impacting patient outcomes and upholding the integrity of medical records. It aligns with the ethical obligation to provide competent care and maintain accurate patient information. Incorrect approaches analysis. One incorrect approach would be to dismiss the discrepancy as a minor clerical error without further investigation. This fails to uphold the professional responsibility to ensure the accuracy of patient records and could lead to misdiagnosis or inappropriate management if the documented innervation were to influence future treatment decisions. It represents a failure in due diligence and a disregard for the potential impact on patient care. Another incorrect approach would be to immediately assume the initial documentation was correct and that the quality control review introduced an error. This demonstrates a lack of critical self-assessment and an unwillingness to consider potential inaccuracies in one's own work or the work of colleagues. It bypasses the opportunity for learning and improvement and could perpetuate incorrect information. A further incorrect approach would be to rely solely on external resources or general knowledge without consulting the specific patient's record and the context of the examination. While general knowledge is crucial, the specific findings and documentation within the patient's chart are paramount for accurate assessment. This approach risks misapplying general principle to a specific clinical situation and overlooks the importance of detailed patient-specific data. Professional reasoning. Professionals should approach such discrepancies with a commitment to accuracy and patient safety. The decision-making process should involve 1. Acknowledging the discrepancy identified by quality control. 2. Initiating a systematic review of all relevant patient data and documentation. 3. Applying established ophthalmological knowledge to interpret the findings. 4. Consulting with colleagues or seeking further diagnostic information if ambiguity persists. 5. implementing corrective actions to rectify the record and prevent future errors. This methodical approach ensures that patient care is based on accurate information and that professional standards are consistently met. Question 2. Implementation of tonometry in a busy ophthalmology clinic requires careful consideration of accuracy, patient safety, and regulatory compliance. A physician is evaluating a new patient with a family history of glaucoma. Which of the following approaches best aligns with the established standards for diagnostic tonometry in the United States? Option A. Utilizing a Goldmann applanation tonometer that has undergone regular calibration checks and is meticulously disinfected between each patient encounter, with results interpreted in conjunction with other clinical findings. Option B. Employing a non-contact tonometer for all patients due to its speed and efficiency, without further confirmation if initial readings are borderline. Option C. Performing tonometry using a handheld applanation device that has not been recently calibrated, assuming it provides a sufficiently close approximation of intraocular pressure. Option D. Relying solely on a single intraocular pressure reading obtained via any available tonometer, without considering diurnal variations or performing confirmatory measurements. Correct answer is A. Utilizing a Goldmann applanation tonometer that has undergone regular calibration checks and is meticulously disinfected between each patient encounter, with results interpreted in conjunction with other clinical findings. Explanation. The scenario presents a common clinical challenge in ophthalmology, ensuring accurate and reliable tonometry measurements, which are critical for diagnosing and managing glaucoma. The professional challenge lies in balancing the need for timely patient care with the imperative to adhere to established protocols and guidelines that ensure data integrity and patient safety. This requires careful judgment in selecting appropriate methods and ensuring proper execution. The correct approach represents best professional practice because it prioritizes patient safety and data accuracy by adhering to established guidelines for tonometry. Specifically, it involves using a Goldmann applanation tonometer (GAT), the gold standard, and ensuring it is properly calibrated and disinfected between patients, aligning with recommendations from professional bodies like the American Academy of Ophthalmology (AO) and regulatory standards for medical device use. This meticulous approach minimizes the risk of iatrogenic complications and ensures that diagnostic decisions are based on reliable information, thereby upholding the standard of care. An incorrect approach that involves using a non-contact tonometer (NCT) without considering its limitations or potential for less accuracy in certain patient populations fails to meet the standard of care. While NCT is convenient, it can be less precise than GAT, and its use without appropriate clinical context or confirmation with GAT when indicated could lead to misdiagnosis or delayed treatment. This represents a failure to exercise due diligence in patient assessment. Another incorrect approach, using a GAT without proper disinfection between patients, poses a significant risk of cross-contamination and infection, a direct violation of infection control standards, and a breach of patient safety protocols. Furthermore, relying solely on a single elevated reading without considering diurnal variation or other clinical factors, as might be implied by a rushed approach, demonstrates a lack of comprehensive diagnostic reasoning and adherence to best practices for glaucoma evaluation. Professional decision-making in such situations should involve a systematic process. First, assessing the patient's clinical presentation and history to determine the most appropriate tonometry method. Second, ensuring all equipment is properly calibrated and maintained. Third, executing the chosen method with meticulous attention to technique and patient comfort. And fourth, interpreting the results within the broader clinical context, considering potential confounding factors and the need for repeat measurements or confirmatory testing. This structured approach ensures that diagnostic procedures are both efficient and effective, prioritizing patient well-being and the integrity of clinical data. Question 3. Cost-benefit analysis shows that implementing a comprehensive visual perception and processing assessment protocol, including referral to specialized services when indicated, is more effective than relying solely on standard visual acuity and visual field testing for patients reporting difficulties with tasks like depth perception and object recognition. Given this, which of the following approaches best aligns with best professional practice for an ophthalmologist evaluating such a patient? Option A. Inform the patient that standard visual acuity and visual field tests are the definitive measures of visual function, and that no further investigation is warranted if these are within normal limits. Option B. Prescribe a broad-spectrum nutritional supplement claimed to improve cognitive function and visual processing. Without further diagnostic workup. Option C. Refer the patient to a neuro-ophthalmologist or vision rehabilitation therapist for further specialized evaluation and management recommendations. Option D. Conclude that the patient's symptoms are likely subjective and not amenable to ophthalmological intervention, advising them to be cautious in visually demanding activities. The correct answer is C. Refer the patient to a neuro-ophthalmologist or vision rehabilitation therapist for further specialized evaluation and management recommendations. Explanation. Scenario analysis. This scenario presents a professional challenge because it involves a patient with a potentially significant visual processing deficit that could impact their safety and quality of life. Ophthalmologists must balance the desire to provide comprehensive care with the practical limitations of diagnostic resources and the patient's subjective experience. The challenge lies in accurately assessing the functional impact of subtle visual processing issues, which are not always directly measurable by standard visual acuity or field testing. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a thorough, multifaceted evaluation of the patient's visual perception and processing. This involves not only standard ophthalmological assessments, but also a referral to a specialist in neuro-ophthalmology or a vision rehabilitation therapist. This referral is crucial for a deeper understanding of the patient's specific deficits, their functional implications, and potential management strategies. This aligns with the American Board of Ophthalmology's emphasis on comprehensive patient care and the ethical obligation to refer when expertise beyond one's own is required. It also reflects the understanding that visual perception is a complex process involving more than just the eye itself, encompassing brain function and interpretation. Incorrect approaches analysis. One incorrect approach involves solely relying on standard visual acuity and visual field testing. This fails to address the core of the patient's complaint, which is related to visual processing, not necessarily refractive error or gross field defects. It is ethically deficient as it does not adequately investigate the patient's reported symptoms and may lead to an incomplete diagnosis and inappropriate management. Another incorrect approach is to dismiss the patient's concerns due to the absence of objective findings on initial examination. This is professionally unacceptable as it invalidates the patient's experience and can lead to significant distress and a lack of appropriate care. Ethically, it violates the principle of patient-centered care and the duty to listen to and investigate patient complaints thoroughly. A third incorrect approach is to immediately prescribe expensive, unproven interventions without a clear diagnosis of the underlying processing deficit. This is not only financially irresponsible, but also ethically questionable, as it exposes the patient to potential harm and expense without a solid evidence base for efficacy in their specific situation. It fails to adhere to the principle of evidence-based medicine. Professional reasoning. Professionals should approach such situations by first conducting a thorough history and physical examination, including standard ophthalmological tests. If symptoms suggest a deficit beyond what can be assessed with these tools, the next step is to consider referral to a subspecialist or allied health professional who has expertise in the suspected area. This systematic approach ensures that all reasonable diagnostic avenues are explored, patient concerns are addressed, and interventions are evidence-based and tailored to the diagnosed condition. Question 4. Investigation of new-onset visual field deficits and optic disc pallor in a patient necessitates a systematic diagnostic approach. Which of the following diagnostic strategies best aligns with the principles of thorough investigation and patient care as expected within the American Board of Ophthalmology's framework? Option A. Extensive investigation of systemic inflammatory markers without initial structural imaging. Option B. Reliance solely on visual acuity and basic confrontation visual field testing. Option C. Comprehensive imaging of the optic nerves, orbits, and intracranial visual pathways. Option D. Immediate initiation of high-dose systemic corticosteroids to address potential inflammation. The correct answer is D. Immediate initiation of high-dose systemic corticosteroids to address potential inflammation. Explanation. Scenario analysis. a patient presents with new-onset visual field deficits and optic disc pallor. Differentiating between an inflammatory optic neuropathy and a compressive lesion is critical as management strategies and prognoses differ significantly. The challenge lies in synthesizing clinical findings, imaging, and potentially electrophysiological data to arrive at the most accurate diagnosis and initiate appropriate treatment promptly, minimizing irreversible vision loss. This requires a systematic approach that considers the differential diagnoses and their implications for patient care. Correct approach analysis. The correct approach involves a comprehensive evaluation that prioritizes diagnostic imaging of the optic nerves and visual pathways, specifically focusing on the orbits and intracranial structures. This aligns with best professional practice as outlined by the American Board of Ophthalmology's emphasis on evidence-based diagnosis and management. Prompt and accurate imaging is essential to identify structural abnormalities such as tumors, aneurysms, or inflammatory masses that could be compressing the optic nerve or affecting the visual pathways. This diagnostic modality provides objective evidence to guide further management, including potential surgical intervention or specific medical therapies, thereby ensuring patient safety and optimizing outcomes. Incorrect approaches analysis. One incorrect approach is to solely rely on visual acuity and basic visual field testing without advanced imaging. This fails to adequately investigate the underlying etiology of the visual field deficit and optic disc pallor, potentially delaying diagnosis of a serious structural or inflammatory cause. Ethically, this represents a failure to provide a thorough diagnostic workup, which could lead to suboptimal patient care and irreversible vision loss. Another incorrect approach is to immediately initiate empiric high-dose corticosteroid therapy without a definitive diagnosis. While inflammation can cause optic neuropathy, this approach risks masking an underlying compressive lesion, making it more difficult to diagnose and treat surgically. This is a regulatory and ethical failure as it deviates from a systematic diagnostic process and could lead to iatrogenic harm by delaying appropriate treatment for a non-inflammatory cause. A third incorrect approach is to focus exclusively on systemic inflammatory markers without considering structural causes. While systemic inflammation can affect the optic nerve, neglecting to rule out mechanical compression or other structural pathologies through appropriate imaging is a diagnostic oversight. This can lead to misdiagnosis and inappropriate treatment, failing to meet the standard of care expected by the American Board of Ophthalmology. Professional reasoning. Professionals faced with such a scenario should employ a structured diagnostic framework. This begins with a detailed history and comprehensive ophthalmologic examination, including visual acuity, pupillary responses, motility, and formal visual field testing. Based on these findings, a differential diagnosis should be formulated. The next crucial step is to obtain appropriate imaging studies, e.g., MRI of the orbits and brain with contrast, to evaluate the optic nerves and surrounding structures for any abnormalities. Further investigations, such as blood work for inflammatory markers or specific serological tests, should be guided by the clinical suspicion and imaging findings. This systematic, evidence-based approach ensures that all potential etiologies are considered and addressed, leading to the most effective and timely management plan. Question 5. The control framework reveals a patient presenting with sudden onset of severe eye pain, decreased visual acuity to counting fingers at 2 feet, and a significant hypopyon in the left eye, occurring 3 days after uneventful cataract surgery. Given these findings, which of the following management strategies is most aligned with current ophthalmological best practices for suspected endophthalmitis? Option A. Administer intravenous broad-spectrum antibiotics and monitor the patient closely for any changes. Option B. Initiate intravitreal vancomycin and ceftazidime injections and obtain vitreous samples for culture and sensitivity testing. Option C. Recommend observation for 24 hours to assess for spontaneous improvement before initiating any invasive procedures. Option D. Prescribe topical corticosteroids and cycloplegic drops and schedule a follow-up appointment in 48 hours. The correct answer is B. Initiate intravitreal vancomycin and ceftazidime injections and obtain vitreous samples for culture and sensitivity testing. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the potential for severe vision loss and the critical need for rapid, evidence-based intervention in a post-operative setting. The challenge lies in accurately identifying the most probable cause of the patient's symptoms from a differential diagnosis, which includes both infectious and sterile inflammatory processes, and initiating the correct management pathway without delay. The stakes are exceptionally high, as delayed or inappropriate treatment for endophthalmitis can lead to irreversible visual impairment, directly impacting the patient's quality of life and the ophthalmologist's professional responsibility. Adherence to established guidelines and best practices is paramount. Correct approach analysis. The correct approach, which involves immediate intravitreal antibiotic injection and prompt vitreous sampling for culture and sensitivity, represents best professional practice as it directly addresses the most urgent and sight-threatening condition, bacterial endophthalmitis. This aligns with the American Academy of Ophthalmology (AO) preferred practice patterns and other consensus guidelines for the management of endophthalmitis. Early administration of antibiotics is crucial to penetrate the vitreous cavity and combat infection before it causes extensive retinal damage. Vitreous sampling is essential for definitive diagnosis and guiding targeted antibiotic therapy, thereby optimizing treatment efficacy and minimizing the risk of antibiotic resistance. This proactive and aggressive management strategy is ethically mandated to preserve vision and fulfill the physician's duty of care. Correct approach is analysis. Initiating topical steroid therapy alone without further investigation or intravitreal intervention is an ethically and professionally unacceptable approach. While inflammation is a component of endophthalmitis, relying solely on topical steroids fails to address the underlying infectious etiology. This delay in administering intravitreal antibiotics could allow the infection to progress unchecked, leading to irreversible vision loss. This constitutes a failure to adhere to established clinical guidelines and a breach of the duty to provide timely and appropriate care. Administering systemic antibiotics as the primary treatment without intravitreal intervention is also professionally unacceptable. While systemic antibiotics may play an adjunctive role in severe cases, they achieve poor penetration into the vitreous cavity, making them insufficient as a sole treatment for established endophthalmitis. This approach delays the critical delivery of high antibiotic concentrations directly to the site of infection, increasing the risk of treatment failure and vision loss. It represents a deviation from best practices and a failure to prioritize the most effective treatment modality. Observing the patient for 24-48 hours without initiating treatment is a dangerous and ethically indefensible approach. The rapid progression of endophthalmitis necessitates immediate action. Delaying treatment for such a period significantly increases the likelihood of severe and permanent visual impairment. This inaction constitutes gross negligence and a failure to uphold the physician's responsibility to act in the patient's best interest when faced with a sight-threatening condition. Professional reasoning. In managing suspected endophthalmitis, professionals should employ a structured decision-making process. This begins with a high index of suspicion based on clinical presentation, e.g., pain, decreased vision, hypopyon, vitritis, in a postoperative or post-traumatic eye. The immediate next step is to differentiate between infectious endophthalmitis and sterile postoperative inflammation. Given the potential for rapid vision loss with infectious endophthalmitis, the priority is to rule out and treat infection aggressively. This involves immediate intravitreal antibiotic administration and obtaining diagnostic samples, vitreous tap for gram stain, culture, and sensitivity. The decision-making process is guided by established guidelines, emphasizing prompt intervention to preserve vision. If the diagnosis remains uncertain after initial sampling, or if the patient fails to improve, further diagnostic and therapeutic interventions, such as pars plana vitrectomy, should be considered. The core principle is to act decisively and effectively to mitigate the risk of irreversible vision loss. Question 6. Stakeholder feedback indicates that some ophthalmologists may be recommending diagnostic imaging services at affiliated outpatient centers where the physician has a financial interest, without fully disclosing this relationship to patients. This practice raises concerns about potential conflicts of interest and the integrity of patient referrals. Considering the ethical obligations and regulatory landscape governing medical practice in the United States, what is the most appropriate course of action for an ophthalmologist in such a situation? Option A. Recommend the affiliated outpatient center for imaging due to its perceived efficiency and quality of service, assuming the patient will benefit from the convenience. Option B. Fully disclose the financial interest in the affiliated outpatient center to the patient. Discuss all available imaging options, including those outside the affiliated center, and allow the patient to make the final decision regarding where to have the imaging performed. Option C. Refer the patient to the affiliated outpatient center for imaging and mention the financial interest only if the patient specifically inquires about potential conflicts. Option D. Strongly encourage the patient to choose the affiliated outpatient center for imaging, emphasizing the benefits of the physician's familiarity with the facility's equipment and protocols. The correct answer is B. Fully disclose the financial interest in the affiliated outpatient center to the patient. Discuss all available imaging options, including those outside the affiliated center, and allow the patient to make the final decision regarding where to have the imaging performed. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from a conflict between a physician's duty to provide optimal patient care and the potential for financial gain through a referral to an affiliated entity. The physician must navigate the ethical imperative of patient well-being and autonomy against the temptation of personal or institutional financial benefit. Transparency and informed consent are paramount to maintaining patient trust and upholding professional integrity. The American Board of Ophthalmology, through its ethical guidelines and the broader regulatory framework governing medical practice in the United States, emphasizes patient-centered care and avoidance of conflicts of interest. Correct approach analysis. The correct approach prioritizes the patient's best interest and informed decision-making. This involves a clear and unbiased discussion of all available treatment options, including those outside the physician's immediate network. The physician must disclose any potential financial relationships with affiliated entities that might influence their recommendations. This aligns with the ethical principles of beneficence, non-maleficence, and patient autonomy, as well as regulations such as Stark Law and the Anti-Kickback Statute, which aim to prevent healthcare fraud and abuse by prohibiting self-referrals for designated health services when the referring physician has a financial interest. Full disclosure ensures the patient can make an informed choice, free from undue influence. Incorrect approaches analysis. An approach that involves recommending the affiliated facility without disclosing the financial relationship is ethically and regulatorily unsound. This constitutes a failure to disclose a material conflict of interest, potentially violating patient trust and leading to a breach of fiduciary duty. It also risks violating federal healthcare fraud and abuse laws, which prohibit kickbacks and self-referrals that can lead to increased costs and compromise quality of care. An approach that focuses solely on the perceived convenience or quality of the affiliated facility without acknowledging the financial ties or offering alternatives is also problematic. While convenience and quality are important considerations, they cannot supersede the ethical obligation of transparency regarding financial interests. This approach may mislead the patient into believing the recommendation is purely objective, when in fact it is influenced by a financial incentive. An approach that pressures the patient to choose the affiliated facility, even with disclosure, crosses the line from informed consent to undue influence. Patients have the right to make decisions about their healthcare without coercion. This behavior undermines patient autonomy and can be seen as a violation of professional ethics and potentially a form of patient steering, which is discouraged by regulatory bodies. Professional reasoning. Professionals facing such situations should employ a decision-making framework that begins with identifying potential conflicts of interest. The next step is to consult relevant ethical guidelines and legal statutes. The core principle should always be the patient's best interest, which necessitates full transparency and the presentation of all viable options. Documentation of discussions, disclosures, and patient decisions is crucial for accountability and protection. When in doubt, seeking guidance from institutional ethics committees or legal counsel is advisable. Question 7. The assessment process reveals a resident physician managing a patient 3 days post-keratoplasty who reports mild discomfort and a sensation of dryness. The resident is considering prescribing a topical anesthetic for symptomatic relief, a broad-spectrum antibiotic for prophylaxis, and a topical corticosteroid for inflammation control. Which of the following approaches best reflects current best practices and regulatory considerations for managing this patient's post-operative care? Option A. Prescribe a topical anesthetic for daily use, a topical antibiotic only if signs of infection appear, and a topical non-steroidal anti-inflammatory drug, NSAID, instead of a corticosteroid, without detailed patient instructions. Option B. Prescribe a short-acting topical anesthetic for as-needed use, a broad-spectrum antibiotic for a defined duration, and a topical corticosteroid with a clear tapering schedule, along with comprehensive patient education on administration and potential side effects. Option C. Administer a long-acting topical anesthetic to ensure prolonged comfort. Continue a broad-spectrum antibiotic indefinitely to prevent any potential infection, and prescribe a high-potency topical corticosteroid at maximum frequency without a specific tapering plan. Option D. Discontinue all topical medications immediately due to the mild nature of the symptoms, relying solely on oral analgesics for comfort and natural healing processes. Correct answer is B. Prescribe a short-acting topical anesthetic for as-needed use, a broad-spectrum antibiotic for a defined duration, and a topical corticosteroid with a clear tapering schedule, along with comprehensive patient education on administration and potential side effects. Explanation. The assessment process reveals a common clinical scenario where a resident physician is managing a patient post-keratoplasty, requiring careful consideration of topical ophthalmic medications. The challenge lies in balancing the need for effective immunosuppression and infection prevention with the potential for adverse drug reactions and the importance of patient adherence to a complex regimen. This scenario is professionally challenging because the resident must not only understand the pharmacological properties of the prescribed medications, but also apply this knowledge within the strict regulatory framework governing ophthalmic practice and patient care, ensuring patient safety and optimal outcomes. The American Board of Ophthalmology exam emphasizes a deep understanding of clinical decision-making, including the appropriate use of medications, adherence to established guidelines, and ethical patient management. The correct approach represents best professional practice because it prioritizes patient safety and evidence-based care. It involves a thorough understanding of the indications, contraindications, potential side effects, and drug interactions of topical anesthetics, antibiotics, and anti-inflammatories, particularly in the context of post-keratoplasty care. This approach aligns with the principles of responsible prescribing, which are implicitly assessed in the American Board of Ophthalmology examination, focusing on patient well-being and adherence to standards of care. It demonstrates a commitment to providing individualized patient care based on the specific clinical presentation and risk factors. Each incorrect approach represents specific regulatory or ethical failures. One incorrect approach might involve prescribing a broad-spectrum antibiotic without clear indication of infection, which could contribute to antibiotic resistance and is not aligned with judicious antibiotic stewardship principles. Another incorrect approach could be the overuse or prolonged use of topical corticosteroids without adequate monitoring for intraocular pressure elevation or cataract formation, failing to adhere to best practices for managing steroid-induced side effects. A third incorrect approach might be the failure to adequately counsel the patient on the proper administration and potential side effects of the prescribed medications, which undermines patient adherence and informed consent, a cornerstone of ethical medical practice. These failures demonstrate a lack of comprehensive understanding of the pharmacological agents and a disregard for patient safety and regulatory expectations for ophthalmic care. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's condition, a review of current evidence-based guidelines for post-keratoplasty management, and a careful consideration of the risks and benefits of each medication. This includes understanding the specific role of each drug class: anesthetics for comfort, antibiotics for prophylaxis, anti-inflammatories for immune modulation, and tailoring the regimen to the individual patient's needs and potential for adverse reactions. Effective communication with the patient regarding the treatment plan, expected outcomes, and potential side effects is also paramount. Question 8. The analysis reveals a 45-year-old contact lens wearer presents with a 2-day history of progressively worsening eye pain, photophobia, and blurred vision in the left eye. On examination, there is significant conjunctival injection, a 3 mm epithelial defect with stromal infiltrate and anterior chamber reaction. The patient reports recent use of tap water to rinse their lenses. Considering the potential for microbial keratitis, which of the following actions is most appropriate? Option A. Prescribe broad-spectrum topical antibiotics and schedule a follow-up appointment in 48 hours. Option B. Advise the patient to discontinue contact lens wear and use artificial tears. Option C. Immediately refer the patient to an ophthalmologist for urgent evaluation and management. Option D. Obtain a corneal scraping for gram stain and culture. Then initiate treatment based on preliminary findings. The correct answer is A. Prescribe broad-spectrum topical antibiotics and schedule a follow-up appointment in 48 hours. Explanation. The analysis reveals a scenario that is professionally challenging due to the potential for rapid vision loss and the need for prompt, accurate diagnosis and management of infectious keratitis. The physician must balance the urgency of the situation with the requirement for thoroughness to avoid misdiagnosis, which could lead to irreversible ocular damage. Adherence to established clinical guidelines and ethical principles is paramount. The correct approach represents best professional practice because it prioritizes patient safety and evidence-based care. Prompt referral to an ophthalmologist is crucial for definitive diagnosis and management of suspected infectious keratitis. This aligns with the American Board of Ophthalmology's emphasis on maintaining the highest standards of patient care and professional competence, ensuring that patients receive specialized treatment from a qualified expert in a timely manner. This approach also reflects the ethical obligation to practice within one's scope of expertise and to seek consultation when necessary. An incorrect approach that involves delaying referral or attempting definitive treatment without specialized ophthalmological assessment would represent a significant regulatory and ethical failure. Such actions could be construed as practicing outside the scope of expertise, potentially violating state medical board regulations and the ethical principles of beneficence and non-maleficence. Failure to promptly diagnose and treat infectious keratitis can lead to severe complications, including corneal scarring, vision impairment, and even blindness, directly contravening the physician's duty to protect the patient's well-being. Furthermore, not adhering to established diagnostic and treatment protocols for infectious keratitis could be seen as a deviation from the standard of care, potentially leading to malpractice claims and disciplinary action. Professional reasoning in such situations should involve a systematic approach. 1. Recognize the potential severity of the symptoms and the possibility of infectious keratitis. 2. Assess the patient's risk factors and perform a focused ocular examination. 3. If infectious keratitis is suspected, prioritize immediate referral to an ophthalmologist for specialized evaluation, including corneal scraping for microscopy and culture, and initiation of appropriate antimicrobial therapy. 4. Document all findings, assessments, and management decisions meticulously. Question 9. The performance metrics show a slight increase in patient-reported discomfort and blurred vision among individuals presenting with symptoms suggestive of external ocular surface disease. A patient presents with a complaint of gritty sensation, redness, and intermittent blurred vision, particularly noticeable in the morning. The patient denies any recent trauma or contact lens wear. Which of the following diagnostic and management strategies best aligns with the expected standard of care for this presentation? Option A. Advise the patient that these symptoms are likely due to dry eye and recommend over-the-counter artificial tears only. Option B. Immediately prescribe a course of broad-spectrum antibiotic eye drops and recommend warm compresses. Option C. Perform a comprehensive ophthalmological examination including visual acuity, slit lamp biomicroscopy of the eyelids and conjunctiva, and fluorescein staining of the cornea. Option D. Refer the patient to a general practitioner for evaluation of potential systemic causes of eye irritation. The correct answer is C. Perform a comprehensive ophthalmological examination including visual acuity, slit lamp biomicroscopy of the eyelids and conjunctiva, and fluorescein staining of the cornea. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient's subjective complaint of discomfort and visual disturbance in the eye requires objective assessment and management. The challenge lies in differentiating between a benign, self-limiting condition and a more serious pathology that could impact vision or ocular health, necessitating appropriate diagnostic steps and treatment. The physician must balance the patient's immediate discomfort with the need for thorough evaluation to ensure optimal outcomes and adherence to professional standards of care. Correct approach analysis. The correct approach involves a comprehensive ophthalmological examination, including a detailed history, visual acuity assessment, slit lamp biomicroscopy of the anterior segment, eyelids, conjunctiva, cornea, and potentially a fluorescein stain to assess for epithelial defects. This systematic evaluation is crucial for accurately diagnosing the cause of the patient's symptoms, such as blepharitis, conjunctivitis, or a foreign body. Adherence to these diagnostic steps aligns with the American Board of Ophthalmology's emphasis on evidence-based practice and thorough patient assessment, ensuring that treatment is targeted and effective, thereby upholding the standard of care expected of a board-certified ophthalmologist. Incorrect approaches analysis. One incorrect approach would be to immediately prescribe broad-spectrum antibiotic eye drops without a definitive diagnosis. This fails to identify the underlying cause, potentially leading to unnecessary antibiotic use, contributing to antimicrobial resistance, and masking a more serious condition. Ethically, this deviates from the principle of do no harm by exposing the patient to potential side effects of medication without clear indication. Another incorrect approach would be to dismiss the patient's symptoms as minor and advise only artificial tears, especially if the examination reveals any signs of inflammation or abnormality. This neglects the physician's duty to investigate symptoms thoroughly and could lead to delayed diagnosis and treatment of a condition that requires specific intervention, potentially resulting in vision impairment or chronic discomfort. This represents a failure to meet the expected standard of care. A third incorrect approach would be to refer the patient to another specialist without performing a basic ophthalmological assessment first. While referrals are sometimes necessary, a board-certified ophthalmologist is expected to perform initial diagnostic evaluations for common ocular complaints related to the external structures. This approach could be seen as an abdication of professional responsibility and may cause unnecessary delays and costs for the patient. Professional reasoning. Professionals should employ a systematic decision-making framework that begins with a detailed patient history, followed by a targeted physical examination. For external eye complaints, this includes assessing visual acuity, inspecting the eyelids and conjunctiva for signs of inflammation, edema, or discharge, and evaluating the cornea for any abrasions or foreign bodies. The use of diagnostic tools like fluorescein staining should be considered based on initial findings. Treatment should be guided by the confirmed diagnosis, with clear communication to the patient regarding the condition, treatment plan, and expected outcomes. This structured approach ensures that patient care is both efficient and effective, minimizing risks and maximizing benefits, in accordance with the ethical and professional standards of ophthalmology. Question 10. Research into the management of a 45-year-old patient presenting with significant myopia and astigmatism, who expresses a strong desire for reduced dependence on corrective lenses for daily activities, requires an ophthalmologist to consider various treatment modalities. Which of the following approaches best reflects current best practices in refractive error management within the American Board of Ophthalmology's regulatory framework? Option A. Immediately recommend LASIK surgery as the primary solution, given the patient's stated desire to reduce lens dependence, without a thorough preoperative assessment of ocular health or a discussion of alternative management strategies. Option B. Conduct a comprehensive eye examination to precisely quantify the refractive error and assess ocular health, followed by a detailed discussion of all appropriate management options, including spectacles, contact lenses, and surgical interventions like LASIK or refractive lens exchange, outlining the risks, benefits, and expected outcomes of each based on the patient's specific findings and lifestyle. Option C. Advise the patient that significant myopia and astigmatism are permanent conditions, and that no effective management options exist beyond traditional eyeglasses, discouraging further exploration of alternatives. Option D. Prescribe the strongest possible prescription for eyeglasses that fully corrects the refractive error, without exploring other modalities or discussing the patient's functional goals beyond achieving 20/20 vision. The correct answer is B. Conduct a comprehensive eye examination to precisely quantify the refractive error and assess ocular health, followed by a detailed discussion of all appropriate management options, including spectacles, contact lenses, and surgical interventions like LASIK or refractive lens exchange, outlining the risks, benefits, and expected outcomes of each based on the patient's specific findings and lifestyle. Explanation. This scenario presents a common clinical challenge in ophthalmology. managing a patient with a significant refractive error and a desire for improved uncorrected vision, while also considering the potential impact on ocular health and the patient's overall well-being. The professional challenge lies in balancing the patient's aesthetic and functional desires with the ophthalmologist's duty of care, which includes providing accurate information about risks, benefits, and alternatives, and ensuring that any proposed intervention is medically appropriate and ethically sound. The American Board of Ophthalmology's framework emphasizes evidence-based practice and patient-centered care, requiring a thorough understanding of refractive error management and its implications. The correct approach represents best professional practice because it prioritizes a comprehensive evaluation and informed consent process, aligning with the ethical principles of beneficence, non-maleficence, and patient autonomy. This involves a detailed assessment of the refractive error, ocular health, and visual needs, followed by a thorough discussion of all available management options, including their respective risks, benefits, and limitations. This approach ensures the patient can make a well-informed decision based on accurate information, thereby upholding the ophthalmologist's responsibility to act in the patient's best interest and adhere to professional standards of care. An incorrect approach that focuses solely on the patient's initial request without a thorough diagnostic workup would be professionally unacceptable. This failure would violate the principle of non-maleficence by potentially recommending an inappropriate or risky intervention without fully understanding the patient's ocular status. It would also undermine patient autonomy by not providing a complete picture of all viable options and their consequences, thus failing the informed consent process. Another incorrect approach, such as dismissing the patient's concerns about their refractive error without offering any solutions or further investigation, would be a dereliction of the ophthalmologist's duty of care and could be considered a failure to provide appropriate medical management, potentially leading to patient dissatisfaction and a breach of professional standards. The professional reasoning process for similar situations should involve a systematic approach. First, conduct a thorough history and physical examination, including a detailed refractive assessment and ocular health evaluation. Second, identify all potential management strategies for the refractive error, considering both conservative and interventional options. Third, educate the patient comprehensively about each option, including expected outcomes, potential complications, and recovery timelines. Fourth, collaboratively develop a treatment plan that aligns with the patient's goals, values, and medical suitability, ensuring that informed consent is obtained prior to any intervention. Question 11. Examination of the data shows a patient presenting with a complaint of blurry vision. During the initial visual acuity testing, the patient exhibits noticeable nystagmus, and the recorded visual acuity is 20/100 in the right eye and 20/150 in the left eye. The patient has not had a recent eye examination and is not wearing corrective lenses. Which of the following approaches best represents the initial management strategy to accurately document the patient's visual acuity? Option A. Attempt to obtain a pinhole visual acuity in each eye to assess for improvement, followed by a formal refraction if acuity improves. Option B. Accept the recorded visual acuity as the patient's baseline and proceed with further diagnostic workup without further acuity refinement. Option C. Immediately proceed with a subjective refraction without attempting any standardized acuity measurement or pinhole testing. Option D. Rely solely on the patient's subjective report of their vision, without using any standardized charts or testing methods. The correct answer is A. Attempt to obtain a pinhole visual acuity in each eye to assess for improvement, followed by a formal refraction if acuity improves. Explanation. Scenario analysis. This scenario presents a common challenge in ophthalmology, ensuring accurate and reproducible visual acuity measurements, which are fundamental to diagnosing vision impairment, monitoring disease progression, and assessing treatment efficacy. Discrepancies in testing methodology can lead to misdiagnosis, inappropriate treatment, and potential patient harm, necessitating a rigorous adherence to established protocols. The challenge lies in identifying the most reliable method for documenting visual acuity in a patient with potential refractive error and nystagmus, where standard testing might be compromised. Correct approach analysis. The correct approach prioritizes obtaining the most accurate and reproducible visual acuity measurement under optimal conditions, as dictated by American Board of Ophthalmology guidelines for clinical practice and patient care. This involves using a standardized chart, e.g., or Snellen at the appropriate distance, ensuring adequate lighting, and employing a pinhole occluder to mitigate the effects of uncorrected refractive error. For patients with nystagmus, allowing them to stabilize their vision through the pinhole, even if it takes slightly longer, is crucial for obtaining a reliable baseline. This method aligns with the ethical obligation to provide competent care and the regulatory expectation of using evidence-based practices to ensure patient safety and diagnostic accuracy. Incorrect approach is analysis. One incorrect approach involves immediately resorting to subjective refraction without first attempting to obtain a reliable best-corrected visual acuity. This bypasses a critical diagnostic step and may lead to an inaccurate assessment of the patient's visual potential, potentially resulting in over- or undercorrection of refractive error. This deviates from standard clinical practice and could be considered a failure to provide adequate diagnostic workup. Another incorrect approach is to accept a lower visual acuity measurement without exploring methods to improve it, such as using a pinhole. This fails to identify the patient's true visual potential and could lead to a misclassification of their visual status, impacting subsequent management decisions. Ethically, this represents a failure to strive for the most accurate diagnosis. A third incorrect approach is to rely solely on subjective refraction without attempting any form of objective acuity measurement or standardized chart testing. This is not a systematic approach and lacks the reproducibility and objectivity required for reliable clinical assessment and documentation, potentially violating standards of care. Professional reasoning. When faced with a patient whose visual acuity is difficult to ascertain due to factors like nystagmus or suspected refractive error, the professional decision-making process should involve a systematic approach. First, attempt to obtain a reliable baseline visual acuity using standardized charts and proper illumination. If acuity is suboptimal, employ a pinhole occluder to rule out or account for refractive error. If refractive error is suspected and the pinhole improves acuity, proceed with a formal refraction to determine the best spectacle correction. Throughout this process, document all findings meticulously, including the methods used and the results obtained at each step. This ensures a comprehensive and accurate assessment, adhering to professional standards and regulatory expectations for patient care. Question 12. The evaluation methodology shows a patient presenting with new-onset visual disturbances. The physician is reviewing diagnostic imaging of the internal ocular structures. Which of the following approaches best reflects a comprehensive and accurate assessment of the cornea, lens, retina, and vitreous body in this context? Option A. A review of the fundus photography for evidence of diabetic retinopathy, without specific consideration for other internal ocular structures. Option B. A detailed analysis of the retinal layers and optic nerve head, alongside an assessment of the lens clarity and anterior chamber depth, while also evaluating the corneal topography and epithelial integrity. Option C. A focused examination of the vitreous humor for opacities, with a cursory glance at the lens for significant cataracts and a brief assessment of the peripheral retina. Option D. An interpretation of the corneal endothelial cell count and a review of the anterior segment optical coherence tomography, with minimal attention to the posterior segment structures. The correct answer is B. A detailed analysis of the retinal layers and optic nerve head, alongside an assessment of the lens clarity and anterior chamber depth, while also evaluating the corneal topography and epithelial integrity. Explanation. The evaluation methodology shows a scenario where a physician must interpret complex imaging findings related to the internal structures of the eye. This is professionally challenging because subtle abnormalities in the cornea, lens, retina, or vitreous body can have significant implications for patient vision and require precise diagnostic acumen. The physician must integrate clinical presentation with imaging data, adhering to established diagnostic standards and ethical obligations to provide accurate and timely care. The correct approach represents best professional practice because it involves a systematic, evidence-based evaluation of all relevant internal ocular structures. This aligns with the American Board of Ophthalmology's commitment to ensuring physicians possess the knowledge and skills to accurately diagnose and manage ophthalmic conditions. Specifically, a thorough assessment of the cornea, lens, retina, and vitreous body, considering their anatomical relationships and potential pathologies, is fundamental to ophthalmological practice and patient safety. This approach prioritizes comprehensive patient care and adherence to diagnostic best practices as expected by the certifying body. An incorrect approach that focuses solely on one internal structure while neglecting others would be professionally unacceptable. This failure to conduct a comprehensive examination violates the ethical duty to provide thorough patient care and could lead to misdiagnoses, delayed treatment, and adverse patient outcomes. Such an approach would also fall short of the rigorous standards expected by the American Board of Ophthalmology, which emphasizes a holistic understanding of ocular anatomy and pathology. Another incorrect approach might involve making a diagnosis based on incomplete or preliminary imaging data without corroborating clinical findings or considering differential diagnoses. This haste and lack of due diligence represent a departure from evidence-based medicine and ethical practice, potentially leading to misdiagnosis and inappropriate management. The professional reasoning process for similar situations should involve a structured approach. First, thoroughly review the patient's history and presenting symptoms. Second, meticulously examine all relevant internal ocular structures using appropriate diagnostic modalities. Third, critically analyze the findings in the context of known pathologies and differential diagnoses. Fourth, consult relevant literature or colleagues if uncertainty exists. And finally, formulate a diagnosis and management plan that is evidence-based, patient-centered, and ethically sound, always striving for the highest standard of care. Question 13. To address the challenge of a patient presenting with blurred vision and eye discomfort, what is the most appropriate initial step in determining the class of ocular medication to prescribe, adhering strictly to the principles and guidelines of the American Board of Ophthalmology? Option A. Recommend over-the-counter artificial tears and advise the patient to monitor symptoms without further in-office evaluation. Option B. Immediately prescribe a broad-spectrum antibiotic to cover potential infections, given the symptoms of discomfort. Option C. Prescribe a topical corticosteroid to reduce inflammation, assuming it is the most common cause of such symptoms. Option D. Conduct a comprehensive ophthalmic examination to establish a definitive diagnosis, and then select medication based on the identified pathology. The correct answer is D. Conduct a comprehensive ophthalmic examination to establish a definitive diagnosis, and then select medication based on the identified pathology. Explanation. Scenario analysis. This scenario presents a common challenge in ophthalmology where a patient's visual needs and potential for ocular pathology necessitate careful consideration of medication classes. The challenge lies in balancing the immediate symptomatic relief with the long-term management of underlying conditions, all while adhering to established clinical guidelines and patient safety protocols. The physician must navigate the complexities of different drug classes, their mechanisms of action, potential side effects, and appropriate indications within the scope of American Board of Ophthalmology standards. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's symptoms and a thorough ophthalmic examination to identify the underlying cause of the visual disturbance. Based on this diagnosis, the physician can then select the most appropriate class of ocular medication. For example, if the patient presents with signs of inflammation, a corticosteroid or non-steroidal anti-inflammatory drug, NSAID, might be indicated. If dry eye is suspected, artificial tears or prescription medications like cyclosporine or lifitegrast would be considered. This diagnostic-driven, evidence-based selection process aligns with the American Board of Ophthalmology's emphasis on patient-centered care and the judicious use of therapeutic agents. It prioritizes efficacy, safety, and adherence to best practices in ophthalmological treatment. Incorrect approaches analysis. An approach that immediately prescribes a broad-spectrum antibiotic without evidence of infection fails to adhere to the principle of targeted therapy. This could lead to unnecessary exposure to medication, potential development of antibiotic resistance, and masking of the true underlying pathology. Disregards the diagnostic process mandated by ophthalmological standards. Another incorrect approach would be to solely focus on symptomatic relief with over-the-counter lubricants without a comprehensive examination. While lubricants can be helpful for dry eye, they do not address inflammatory or infectious causes of visual disturbance, potentially delaying appropriate treatment and allowing a condition to worsen. This neglects the diagnostic and therapeutic responsibilities outlined by the American Board of Ophthalmology. Prescribing a medication class with known contraindications for the patient's medical history without considering alternatives represents a significant ethical and regulatory failure. Patient safety is paramount, and overlooking pre-existing conditions or drug interactions is a direct violation of the duty of care expected of a board-certified ophthalmologist. Professional reasoning. Professionals should approach such situations by first prioritizing a thorough patient history and comprehensive ophthalmic examination. This diagnostic phase is crucial for identifying the root cause of the visual complaint. Following diagnosis, the physician should consult current clinical guidelines and evidence-based literature to determine the most appropriate class of ocular medication. This involves considering the mechanism of action, efficacy, safety profile, potential side effects, and patient-specific factors such as allergies, comorbidities, and concurrent medications. A stepwise approach, starting with the least invasive and most targeted therapy, is generally preferred. Regular follow-up is essential to monitor treatment response and adjust the therapeutic plan as needed. Question 14. Analysis of a 78-year-old patient presenting with a mature nuclear cataract in their left eye, significantly impacting their vision and ability to perform daily activities. The patient, however, expresses a strong desire to postpone surgery due to financial concerns and a general apprehension about the procedure. Despite understanding the potential risks and benefits discussed, the physician has assessed the patient's cognitive function and believes they have the capacity to make decisions, but also recognizes that the delay could lead to further visual deterioration and potential complications. What is the most ethically and professionally appropriate course of action for the ophthalmologist? Option A. Recommend immediate surgery, emphasizing the severe visual impairment and potential for irreversible damage, overriding the patient's expressed wishes due to the perceived urgency. Option B. Refer the patient to a social worker to address their financial concerns without further discussion of the medical necessity of surgery, leaving the decision solely to the patient's financial situation. Option C. Proceed with scheduling the cataract surgery, explaining that the delay is medically inadvisable and that the patient's financial concerns can be addressed through available assistance programs. Option D. Respect the patient's stated desire to postpone surgery. Document the discussion thoroughly and schedule a follow-up appointment to reassess the situation and explore alternative financial solutions or coping strategies. The correct answer is C. Proceed with scheduling the cataract surgery, explaining that the delay is medically inadvisable and that the patient's financial concerns can be addressed through available assistance programs. Explanation. Scenario analysis. This scenario presents a common ethical dilemma in ophthalmology, balancing patient autonomy with the physician's duty of care, particularly when a patient's understanding of their condition and treatment options may be compromised. The challenge lies in determining the appropriate level of intervention and communication when a patient, due to their cognitive state or a specific type of cataract, may not fully grasp the implications of delaying surgery. The American Board of Ophthalmology's framework emphasizes patient-centered care and informed consent, requiring physicians to navigate situations where a patient's capacity to consent might be questioned or where the progression of a condition poses a significant risk. Correct approach analysis. The correct approach prioritizes a thorough assessment of the patient's cognitive capacity and the specific impact of their cataract on their vision and daily functioning. This involves engaging in a detailed discussion with the patient, using clear and understandable language, and assessing their comprehension. If the patient demonstrates sufficient understanding and capacity to make decisions, their wishes regarding delaying surgery, even if not medically optimal, must be respected, provided there is no immediate threat to their vision or safety. If capacity is questionable, involving a surrogate decision-maker or seeking a formal capacity assessment becomes paramount, aligning with ethical principles of beneficence and non-maleficence while upholding patient rights. This approach adheres to the principles of informed consent and patient autonomy, core tenets of medical ethics and professional conduct, as expected by the American Board of Ophthalmology. Incorrect approaches analysis. One incorrect approach involves proceeding with surgery against the patient's stated wishes, even if the physician believes it is in the patient's best interest. This violates the principle of patient autonomy and informed consent, which are fundamental ethical and regulatory requirements. The American Board of Ophthalmology expects physicians to respect a patient's right to refuse treatment, provided they have the capacity to do so. Another incorrect approach is to dismiss the patient's concerns or delay a thorough assessment of their visual impairment and cognitive status, simply because the cataract is not yet severe by objective measures. This fails to acknowledge the subjective impact of vision loss on a patient's quality of life and independence, and it neglects the physician's duty to investigate and address potential underlying causes or contributing factors to the patient's reluctance or confusion. This could also be seen as a failure to act with beneficence if the delay leads to significant functional decline. A third incorrect approach is to make assumptions about the patient's capacity or understanding without direct assessment or consultation with appropriate parties. This can lead to paternalistic decision-making that undermines patient rights and trust. The regulatory framework requires a proactive and diligent approach to ensuring informed consent and respecting patient decision-making capacity. Professional reasoning. Professionals facing such a situation should employ a structured decision-making process. First, assess the patient's current visual function and the specific type and severity of their cataract. Second, engage in a clear, empathetic, and comprehensive discussion about the diagnosis, prognosis, treatment options including risks, benefits, and alternatives, and the implications of delaying treatment. Third, assess the patient's capacity to understand this information and make a reasoned decision. This assessment should be documented. If capacity is present, respect the patient's decision. If capacity is questionable, involve family or a designated surrogate or seek a formal capacity evaluation. Throughout this process, maintain open communication and a patient-centered approach, adhering to the ethical and professional standards set forth by the American Board of Ophthalmology. Question 15. The monitoring system demonstrates a series of Humphrey visual field tests for a patient with suspected early glaucoma. The most recent test shows a single, isolated point of reduced sensitivity in the superior nasal periphery, which is outside the typical range of normal variability for this specific test protocol. However, the reliability indices for this test are excellent, and previous visual fields have shown no significant progression. Which of the following interpretations of this finding best reflects best professional practice for managing suspected glaucoma progression? Option A. Adjust the visual field testing parameters to a more sensitive setting for the next test to better capture any subtle changes. Option B. Disregard the finding entirely, as previous visual fields have shown no progression and a single abnormal point is likely a transient fluctuation. Option C. Initiate immediate treatment intensification based on the single abnormal point, as any deviation from normal warrants intervention. Option D. Document the finding and schedule a repeat visual field test in a shorter interval to confirm the reliability and pattern of the abnormality before considering any changes in management. Correct answer is C. Initiate immediate treatment intensification based on the single abnormal point, as any deviation from normal warrants intervention. Explanation. This scenario presents a common challenge in ophthalmology, interpreting subtle changes in visual field results over time to detect progression of a condition like glaucoma. The difficulty lies in distinguishing true disease progression from artifact or normal variability, which requires a nuanced understanding of visual field testing principles and the specific disease being monitored. Professionals must balance the need for early detection to prevent irreversible vision loss with avoiding overtreatment based on spurious findings. This requires careful consideration of multiple factors beyond a single test result. The correct approach represents best professional practice by integrating multiple data points and considering the clinical context. It aligns with the ethical obligation to provide patient-centered care, ensuring that treatment decisions are based on a comprehensive assessment of the patient's condition and the reliability of the data. This approach adheres to the principles of evidence-based medicine, which emphasizes the use of validated methods and the consideration of all available information to guide clinical decisions. Specifically, it reflects the standard of care in ophthalmology for managing progressive visual field defects, which necessitates a longitudinal view and consideration of test reliability. An incorrect approach that relies solely on a single, isolated abnormal point, without considering the overall pattern or test reliability, would be a failure to adhere to the standard of care. This could lead to unnecessary interventions, patient anxiety, and potential harm from treatment side effects. Ethically, it represents a failure to act in the patient's best interest by making decisions based on incomplete or potentially misleading information. Another incorrect approach, such as dismissing a consistent pattern of visual field loss because it doesn't meet a predefined statistical threshold for progression without considering the clinical significance or the patient's overall visual function, would also be a failure. This could delay necessary treatment, leading to irreversible vision loss and violating the duty of care. Professionals should employ a decision-making framework that involves 1. Reviewing the current visual field with attention to the overall pattern of sensitivity loss, not just isolated points. 2. Comparing the current results to previous reliable visual fields, looking for statistically significant and clinically meaningful changes. 3. Assessing the reliability indices of the visual field test to identify potential artifacts. 4. Considering the patient's clinical history, intraocular pressure, optic nerve appearance, and other relevant ophthalmological findings. And 5. Discussing the findings with the patient and formulating a management plan based on the totality of the evidence. This systematic approach ensures that diagnostic and therapeutic decisions are well-founded and patient-specific. Question 16. The performance metrics show that a 15-month-old patient is presenting for a routine ophthalmological examination, and the primary goal is to assess their visual acuity. Given the patient's age and developmental stage, which of the following approaches would be most appropriate for determining their visual acuity? Option A. Using a log MAR chart requiring the child to read the optotypes. Option B. Presenting a modified Snellen chart with picture symbols, expecting the child to name them. Option C. Employing a visual acuity chart designed for infants and young children that utilizes preferential looking paradigms. Option D. Administering a standard Snellen chart, asking the child to identify letters. Correct answer is C. Employing a visual acuity chart designed for infants and young children that utilizes preferential looking paradigms. Explanation. Scenario analysis. This scenario presents a common challenge in pediatric ophthalmology where standard visual acuity testing methods may not be directly applicable or yield reliable results due to the patient's age and developmental stage. The ophthalmologist must select an appropriate visual acuity assessment tool that is both accurate and sensitive enough to detect subtle visual deficits in a young child, while also adhering to established clinical guidelines and best practices for pediatric eye care. The challenge lies in balancing the need for objective measurement with the practical limitations of testing a non-cooperative or preverbal child. Correct approach analysis. Utilizing a visual acuity chart specifically designed for infants and young children, such as the Teller Acuity Cards or the Cardiff Acuity Test, represents best professional practice. These tests employ preferential looking paradigms, where the child's gaze is directed towards a target with gratings of varying spatial frequencies. This method is validated for assessing visual acuity in this age group and is consistent with guidelines from professional ophthalmological bodies that emphasize age-appropriate testing. The American Board of Ophthalmology's focus on evidence-based practice and patient-centered care supports the use of tools that provide the most reliable and meaningful data for diagnosis and management in pediatric populations. Incorrect approach is analysis. Employing a standard Snellen chart with a young child who cannot reliably read letters or follow instructions is a significant regulatory and ethical failure. The Snellen chart is designed for literate individuals and relies on verbal responses, making it inappropriate and invalid for infants and toddlers. This approach fails to meet the standard of care for pediatric visual acuity assessment and could lead to misdiagnosis or delayed detection of visual impairments. It violates the ethical principle of beneficence by not providing the best possible care and potentially causing distress to the child without yielding useful information. Attempting to use a log MAR chart with a preverbal child is also professionally unacceptable. While log MAR charts offer a more standardized and continuous scale than Snellen charts, they still require the patient to identify letters or symbols, which is beyond the capability of very young children. This approach, like the Snellen chart, is not designed for this age group and would result in unreliable data, potentially leading to inappropriate clinical decisions. It represents a failure to adhere to established pediatric ophthalmological protocols and a lack of understanding of the developmental limitations of the patient. Using a modified Snellen chart with pictures, e.g., HODV or Lee symbols, might be considered in older toddlers or preschool-age children who can recognize pictures but not letters. However, if the child is too young to reliably identify these symbols or is not cooperative. This method would also be insufficient, while closer to an appropriate approach than a standard Snellen or log-MAR chart. It still carries the risk of being an inadequate assessment if the child's developmental stage or cooperation level does not align with the test's requirements, potentially leading to an incomplete or inaccurate visual acuity measurement. Professional reasoning. When assessing visual acuity in pediatric patients, the ophthalmologist must first consider the child's age and developmental stage. The primary goal is to obtain the most accurate and reliable visual acuity measurement possible within the constraints of the child's abilities. This involves selecting an assessment tool that is validated for the specific age group and can be administered effectively. The decision-making process should involve reviewing established pediatric ophthalmological guidelines, considering the child's behavior and cooperation level during the examination, and choosing the most appropriate testing modality that aligns with evidence-based practice and ethical standards of care. Question 17. What factors determine the appropriate communication strategy when a patient presents with a suspected ocular muscle disorder and their preconceived notion of the diagnosis differs significantly from the physician's preliminary objective findings regarding extraocular muscle function and innervation? Option A. The physician's desire to quickly confirm the patient's suspected diagnosis to expedite treatment, regardless of objective findings. Option B. The physician's inclination to avoid potentially upsetting the patient by downplaying the severity of the findings or offering a vague explanation. Option C. The physician's ability to accurately diagnose the specific extraocular muscle dysfunction and its underlying innervation, coupled with a commitment to transparently communicate these findings and their implications to the patient, fostering informed decision-making. Option D. The physician's personal opinion on the patient's understanding of medical terminology and their perceived ability to comprehend complex neurological or muscular explanations. The correct answer is C. The physician's ability to accurately diagnose the specific extraocular muscle dysfunction and its underlying innervation, coupled with a commitment to transparently communicate these findings and their implications to the patient, fostering informed decision-making. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent conflict between a physician's duty to provide accurate diagnostic information and the patient's desire for a specific, potentially inaccurate diagnosis. The physician must navigate the ethical imperative of truthfulness and patient autonomy while ensuring the patient receives appropriate care based on a correct understanding of their condition. Misrepresenting the diagnosis, even with good intentions, erodes trust and can lead to suboptimal treatment or delayed intervention. Correct approach analysis. The correct approach prioritizes clear, honest communication about the ocular muscle findings and their implications for the patient's vision and eye alignment. This aligns with the ethical principles of beneficence, acting in the patient's best interest by providing accurate information for proper management, and autonomy, respecting the patient's right to make informed decisions based on truthful data. Specifically, it upholds the American Board of Ophthalmology's implicit commitment to evidence-based practice and accurate patient education, which are foundational to ethical medical care. Providing a detailed explanation of the specific muscle dysfunction and its likely cause, while acknowledging the patient's concerns, allows for collaborative decision-making regarding treatment options. Incorrect approaches analysis. One incorrect approach involves confirming the patient's self-diagnosis without objective verification. This fails to uphold the physician's responsibility to provide an accurate medical assessment. Ethically, it violates the principle of non-maleficence by potentially leading the patient down an incorrect diagnostic and treatment path, which could be harmful. It also undermines patient autonomy by not providing them with the true information needed for informed consent. Another incorrect approach is to dismiss the patient's concerns outright without a thorough examination and explanation. This demonstrates a lack of empathy and disrespect for the patient's experience and autonomy. It can lead to patient dissatisfaction and a breakdown in the physician-patient relationship, failing to meet the standards of compassionate care expected within the medical profession. A third incorrect approach is to provide a vague or misleading explanation that avoids directly addressing the discrepancy between the patient's belief and the objective findings. This is a form of deception, which is ethically unacceptable. It prevents the patient from understanding their true condition and making informed decisions, thereby violating their autonomy and potentially compromising their care. Professional reasoning. Professionals should approach such situations by first conducting a comprehensive examination to establish objective findings. Following this, they should engage in open and empathetic communication, validating the patient's concerns while clearly and accurately explaining the medical findings. This involves using understandable language to describe the specific ocular muscle dysfunction, its innervation, and the resulting visual or alignment issues. The physician should then discuss potential treatment options based on the accurate diagnosis, empowering the patient to participate actively in their care decisions. This process fosters trust, ensures informed consent, and promotes the best possible patient outcomes, adhering to the ethical and professional standards of the American Board of Ophthalmology. Question 18. The control framework reveals a patient with open-angle glaucoma, previously well controlled on a topical beta blocker and a prostaglandin analog, who now presents with symptomatic bradycardia. The physician must reassess the management strategy. Which of the following represents the most appropriate immediate course of action? Option A. Continue the topical beta blocker as it is essential for IOP control and manage the bradycardia symptomatically with other interventions. Option B. Discontinue the topical beta blocker and consider alternative IOP-lowering agents, such as a prostaglandin analog or a carbonic anhydrase inhibitor, while closely monitoring the patient's cardiovascular status. Option C. Increase the dosage of the topical beta blocker to overcome the bradycardia and maintain IOP control. Option D. Immediately switch to a different class of topical medication, such as a Rho kinase inhibitor, without discontinuing the beta blocker, to compensate for potential reduced efficacy. The correct answer is B. Discontinue the topical beta blocker and consider alternative IOP-lowering agents, such as a prostaglandin analog or a carbonic anhydrase inhibitor, while closely monitoring the patient's cardiovascular status. Explanation. This scenario presents a common clinical challenge in ophthalmology, managing a patient with glaucoma who has developed a contraindication to a previously effective medication. The professional challenge lies in balancing the need for effective intraocular pressure, IOP, lowering with the patient's safety, and the potential for systemic side effects. The physician must consider the patient's overall health, other medications, and the specific risks associated with each class of glaucoma medication. Careful judgment is required to select an alternative that is both efficacious and safe, minimizing the risk of adverse events. The correct approach represents best professional practice because it prioritizes patient safety and adherence to established clinical guidelines for glaucoma management. By discontinuing the beta blocker due to the new onset of bradycardia and exploring alternative IOP-lowering agents, the physician is acting in accordance with the American Board of Ophthalmology's emphasis on evidence-based medicine and patient-centered care. This approach aligns with the ethical principle of non-maleficence, do no harm, and beneficence, act in the patient's best interest. Regulatory frameworks, while not explicitly detailed in this context, implicitly support such prudent clinical decision-making by emphasizing physician responsibility for patient well-being and adherence to standards of care. An incorrect approach of continuing the beta blocker, despite the bradycardia, would represent a significant regulatory and ethical failure. It directly violates the principle of non-maleficence, as the medication is demonstrably causing harm. This could lead to serious cardiovascular complications and potential legal ramifications for the physician. Furthermore, failing to adequately monitor and respond to adverse drug reactions undermines the physician's professional responsibility and the trust inherent in the patient-physician relationship. Another incorrect approach of immediately switching to a different class of medication without a thorough assessment of the patient's specific needs and potential contraindications for that new class would also be professionally unacceptable. While the intent might be to quickly regain IOP control, it risks introducing new adverse effects or failing to address the underlying reasons for the previous medication's ineffectiveness or intolerance. This demonstrates a lack of comprehensive patient evaluation and a failure to apply a systematic approach to medication management. The professional decision-making process for similar situations should involve a systematic evaluation. 1. Identify the primary problem, e.g., elevated IOP adverse drug reaction. 2. Assess the patient's overall health status and comorbidities. 3. Review current medications and identify potential drug interactions or contraindications. 4. Consider the efficacy and safety profile of alternative treatment options. 5. Discuss the risks and benefits of each option with the patient. 6. Implement the chosen treatment plan and monitor for efficacy and adverse effects. 7. Document all decisions and patient communications thoroughly. Question 19. Regulatory review indicates that a 5-year-old child presents with bilateral red eyes and watery discharge for 2 days. The child has a mild fever and has been in close contact with other children at daycare who have had similar symptoms. The ophthalmologist is considering the most appropriate initial risk assessment strategy. Which of the following strategies best aligns with best professional practice and regulatory expectations for managing pediatric conjunctivitis? Option A. Refer the patient to a pediatric infectious disease specialist for further evaluation before initiating any treatment. Option B. Prescribe symptomatic relief with artificial tears and advise the parent to return only if symptoms worsen significantly, assuming a self-limiting viral etiology. Option C. Form a thorough history and physical examination, including assessment of discharge characteristics, presence of itching or photophobia, and systemic symptoms, to guide the differential diagnosis and risk stratification for bacterial, viral, or allergic conjunctivitis. Option D. Immediately initiate broad-spectrum topical antibiotic therapy to cover common bacterial pathogens, given the bilateral presentation and daycare setting. The correct answer is D. Immediately initiate broad-spectrum topical antibiotic therapy to cover common bacterial pathogens, given the bilateral presentation and daycare setting. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a child with conjunctivitis, requiring the ophthalmologist to differentiate between bacterial, viral, and allergic etiologies. The challenge lies in the overlapping clinical presentations and the potential for misdiagnosis, which can lead to inappropriate treatment, prolonged discomfort, and potential complications. Furthermore, the physician must consider the specific regulatory requirements for pediatric eye care, including informed consent, documentation, and adherence to evidence-based guidelines for managing infectious and inflammatory conditions. The risk assessment approach is crucial to ensure patient safety and optimize outcomes. Correct approach analysis. The correct approach involves a systematic risk assessment that prioritizes accurate diagnosis and appropriate management based on the most likely etiology, while also considering potential red flags for more serious conditions. This aligns with the American Board of Ophthalmology's emphasis on evidence-based practice and patient-centered care. By performing a thorough history and physical examination, including assessment of discharge characteristics, associated symptoms, fever, photophobia, itching, and exposure history, the physician can stratify the risk of each potential diagnosis. This methodical approach minimizes the risk of delayed or incorrect treatment, thereby upholding professional standards and ethical obligations to provide competent care. Incorrect approach is analysis, an approach that solely relies on empirical treatment without a structured diagnostic process, such as immediately prescribing broad-spectrum antibiotics for all cases of conjunctivitis, represents a failure in risk assessment. This can lead to unnecessary antibiotic use, contributing to antimicrobial resistance, and may mask or delay the diagnosis of viral or allergic conjunctivitis, for which antibiotics are ineffective. This deviates from best practices by not tailoring treatment to the specific condition and potentially causing harm. Another incorrect approach would be to dismiss the possibility of a more serious underlying condition, such as keratitis or uveitis, based on a superficial assessment. This failure to consider a broader differential diagnosis and perform a comprehensive ophthalmologic examination, especially if red flags are present, constitutes a significant lapse in professional judgment and a potential violation of the duty of care. It overlooks the critical need for a thorough risk assessment to rule out sight-threatening pathologies. Failing to adequately document the clinical findings, diagnostic reasoning, and treatment plan is also a regulatory and ethical failure. Comprehensive documentation is essential for continuity of care, legal protection, and adherence to professional standards. Without it, it becomes difficult to track patient progress, justify treatment decisions, or defend against potential malpractice claims. Professional reasoning. Professionals should approach such cases by first gathering a detailed history, focusing on symptom onset, duration, character of discharge, associated symptoms, and any known exposures or allergies. This is followed by a comprehensive physical examination, including visual acuity, external examination, slit lamp biomicroscopy, and potentially a fluorescein stain if corneal involvement is suspected. Based on these findings, a differential diagnosis is formulated, and the risk of each condition is assessed. Treatment is then initiated based on the most probable diagnosis and the assessed risk, with a clear plan for follow-up and reassessment. This systematic, evidence-based approach ensures that patient care is both effective and safe, adhering to the highest professional and ethical standards. Question 20. Governance review demonstrates a need to enhance the integration of cutting-edge research on the phototransduction cascade into the clinical management of inherited retinal degenerations. A physician is presented with novel preclinical findings, suggesting a specific molecular target within the phototransduction pathway that, if modulated, could theoretically slow or reverse photoreceptor cell death. The physician must determine the most appropriate course of action regarding this information in their patient interactions and clinical decision-making. Option A. Thoroughly evaluate the preclinical data, cross-reference with existing clinical trial registries and peer-reviewed literature for any human studies, and discuss the findings with patients only as a potential future research direction, emphasizing the current lack of established clinical efficacy and safety. Option B. Rely on information shared in online patient forums and anecdotal reports from other physicians regarding the experimental therapy to guide discussions with patients about its potential benefits. Option C. Disregard the preclinical findings as purely academic and not relevant to current clinical practice, continuing to manage patients solely based on established, albeit less advanced, treatment modalities. Option D. Immediately inform all patients with relevant inherited retinal degenerations about the promising preclinical findings, encouraging them to seek out experimental treatments based on this research, regardless of their current stage of clinical validation. The correct answer is A. Thoroughly evaluate the preclinical data, cross-reference with existing clinical trial registries and peer-reviewed literature for any human studies, and discuss the findings with patients only as a potential future research direction, emphasizing the current lack of established clinical efficacy and safety. Explanation. Scenario analysis. This scenario presents a challenge in translating fundamental scientific understanding of phototransduction into effective clinical management of inherited retinal diseases. The physician must navigate the complexities of a rapidly evolving research landscape, the ethical considerations of experimental therapies, and the need for clear, evidence-based communication with patients. The challenge lies in discerning which research findings are sufficiently robust and clinically relevant to inform patient counseling and potential treatment pathways, while adhering to the rigorous standards of the American Board of Ophthalmology. Correct approach analysis. The correct approach represents best professional practice by prioritizing a thorough understanding of the molecular mechanisms of phototransduction and their direct implications for specific retinal diseases. This involves staying abreast of peer-reviewed literature, understanding the limitations of preclinical data, and critically evaluating the evidence supporting any proposed therapeutic interventions. The American Board of Ophthalmology's framework emphasizes a strong foundation in basic science as the bedrock for clinical decision-making and patient care. This approach ensures that any discussion of novel treatments is grounded in scientific validity and patient safety, aligning with the ethical imperative to provide evidence-based care and avoid premature adoption of unproven therapies. Incorrect approach is analysis. One incorrect approach involves prematurely advocating for experimental therapies based solely on promising preclinical data without sufficient clinical validation. This fails to meet the standards of evidence-based medicine and could lead to patient harm or false hope, violating ethical principles of beneficence and non-maleficence. It also bypasses the rigorous review processes expected within the ophthalmology field, potentially misrepresenting the current state of knowledge. Another incorrect approach is to dismiss all research related to phototransduction as purely academic and irrelevant to clinical practice. This demonstrates a lack of engagement with scientific advancements that could lead to future treatments for blinding diseases. It represents a failure to embrace the dynamic nature of medical knowledge and a missed opportunity to advocate for or participate in the development of novel therapeutic strategies, which is implicitly encouraged by the pursuit of excellence in ophthalmology. A third incorrect approach is to rely on anecdotal evidence or non-peer-reviewed sources for information on phototransduction and its therapeutic implications. This is a direct contravention of the scientific rigor expected by the American Board of Ophthalmology and can lead to the dissemination of misinformation. It undermines the credibility of the physician and the profession, as well as potentially endangering patients who might be influenced by unsubstantiated claims. Professional reasoning. Professionals should adopt a systematic approach to integrating new scientific knowledge. This involves continuous learning through reputable sources, critical appraisal of research, and a clear understanding of the translational gap between laboratory findings and clinical application. When considering novel therapeutic avenues, a physician should always ask, is there robust clinical evidence? What are the potential risks and benefits? Is this aligned with current accepted standards of care or within a well-defined investigational protocol? This structured decision-making process ensures that patient care is always prioritized and guided by the highest standards of scientific integrity and ethical practice.